I'm going to try to, well, this is a session in acute kidney injury. I think it's important to realize that critical care nephrology is more than just acute kidney injury. And hyponatremia, I think, is one of the things that people struggle with quite a bit. So we're going to cover some management issues and giving a very practical approach to severe acute hyponatremia. So we'll describe clinical features. We'll outline appropriate therapies and why those therapies really have evolved over the years, and talk about what the rate of correction should be for patients with acute severe hyponatremia. So in terms of clinical features for acute hyponatremia, it's defined as hyponatremia, low serum sodium less than 135, that develops in less than 24 hours and is associated with cerebral edema, leading to seizures, coma, respiratory arrest, sometimes with actually very little warning. Now, one of the concomitant complications is a neurogenic pulmonary edema that occurs probably due to the cerebral edema. There seems to be a brain pulmonary reflex that leads to pulmonary edema in these patients. There's a risk of herniation, particularly in younger patients, young women and children. Now, one question to you is, how much is correction of hyponatremia really to reverse the symptoms of severe acute hyponatremia? What does the literature tell us? So is it 2, 5, 8, or 10? And since we don't have a system here, the answer really is 5 milliequivalents per liter. Let me show you the evidence base of why that number has evolved. And really, if you go back in the literature, the first successful treatment of acute severe hyponatremia was reported in 1938. And this was in a 64-year-old woman who, after hysterectomy, was given 8 liters of fluid, and 36 hours postoperatively developed signs of acute severe hyponatremia with severe neurological symptoms. She was treated with a bolus of 130 milliliters of IV 5% saline, equivalent to 217 mils of 3% saline, and her symptoms completely reversed. And this is really the first evidence of using hypertonic saline to reverse the symptoms of acute severe hyponatremia. In fact, subsequently, in one of the first editions of Harrison's sort of seminal textbook of internal medicine, they actually got it right. Without any evidence base, this was just by clinical experience, they basically recommended the infusion of 100 to 300 milliliters of hypertonic saline in the rare patient who had symptoms of water intoxication. Now, moving into the more modern day, what's the evidence base for that being correct? Well, so one of the evidence bases actually occurs in people who get acute severe hyponatremia associated with endurance athletic events. It's something that I've spent most of my career studying. And what we've learned in these athletes is that in the field, if you give them 100 milliliters of a bolus of 3% saline, and even repeat that up to 2 to 3 times, they miraculously recover. They will go from having seizures, being completely obtunded, to actually walking home from the event after getting a small bolus of hypertonic saline. Now, probably the reason for this is from this graph. This is a graph that looks at the relationship between brain volume and intracranial pressure. And there's 3 graphs here. There's the child, there's the adult, and the elderly. And what you see is that there's a fairly exponential relationship between intracranial pressure and intracranial volume. So as volume increases, you get really a tipping point, after which intracranial pressure rises precipitously. That causes CSF displacement, vascular compression, and in the extreme, brainstem herniation. And you can see that the relationship between pressure and volume is displaced so that in children, the tolerance for the changes in volume leading to changes in pressure are much less than in the elderly patient, who can tolerate much greater changes in intracerebral volume, intracranial volume, because they have a lot of atrophy. There's a lot more space in the brain really to tolerate those changes in cellular volume. Now, the neurosurgeons have actually known this for a long time, that they induce therapeutic hyponatremia for patients that develop cerebral edema. And typically their protocol runs like this: about 30 cc's of a very hypertonic saline, 23.4%, which is equivalent to 234 mils of 3%. And that causes a change in serum sodium of about 5 milliequivalents.
And typically will decrease the intracranial pressure by about 40% and reverse the symptoms of cerebral edema very effectively. Now, we also have an evidence base that's based upon case reports. There's a group of us that get together every few years. We look at every case report in the literature on hyponatremia. And what you see consistently is that 4 to 6 milliequivalents in terms of a rise in serum sodium is enough really to reverse the signs and symptoms of acute severe hyponatremia. You really don't have to go more than that to see that those signs almost completely reverse. So how do you do this? This is a quick and dirty algorithm. This works, I would say, almost every time. But just remember that 3% saline is 512 milliequivalents per liter, or roughly about a half milliequivalent of sodium per milliliter. If you assume that total body water is about 0.5 liters per kilo of body weight, therefore 1 mil of 3% per kilo will lead to a change in serum sodium of 1 milliequivalent per liter. Now, there's some caveats to this. There's a greater rise if the urine is becoming dilute, so the patient is sort of self-correcting. And there'll be a salt-molar increase if the urine sodium is very high, if the patient is really concentrated in the urine. But overall, if it's in the middle of the night and you're sleepy and trying to figure out how much saline to give, if you're using 3%, 1 milliliter per kilo will lead to rise in serum sodium of 1 milliequivalent per liter. So a question always arises in many ICUs or on the floor, can hypertonic saline be safely administered via peripheral vein? A practical clinical question. And the answer really is that it can. And there's an evidence base for that comes from this paper by Juan Carlos Ayas that showed that a peripheral vein is certainly okay. There's no reported cases of extravasation injury or venous sclerosis. This is a case series of 64 individuals who received 3% hypertonic saline through a peripheral vein. And if you look back again in the literature, the mandate for using a central vein for hypertonic saline was actually based upon one pharmacy textbook, and it was extrapolated from the use of very hyperosmotic concentrated glucose solutions. So peripheral veins are fine and quite safe for the correction of acute severe hyponatremia. Now, what about other therapies? We have the drugs that are vasopressin 2 receptor antagonists that can be used for the correction of hyponatremia. Now, what about using them for acute severe hyponatremia? Is there evidence base for that? Well, there's one study in the literature that looks at the acute rate of correction when you use a Vaptan drug. And in this study, about 2/3 of the patients had an increase of more than 4 milliequivalents per liter in 24 hours. Less than half of those patients actually had a rise that would be therapeutic for acute severe hyponatremia of more than 4 to 5 milliequivalents within 6 hours. So the rises in serum sodium when you use these pharmacological agents really are not fast enough. They're not going to account for the ability to reverse the signs and symptoms of acute severe hyponatremia. Now, just to touch on some issues in chronic hyponatremia, because I think this comes up in that many patients, in fact, when you look at the majority of patients with acute severe hyponatremia, many of those patients occur in the background of chronic hyponatremia. These are patients who have a duration that's known to be more than 48 hours. And basically, you want to assume that most cases are chronic that develop outside the hospital and are patients that are drinking conventional volumes of water. Those are patients that are typically not the psychogenic polydipsia, not endurance athletes, not a patient that's been ingesting drugs like ecstasy. Now, the goals here is really to develop a strategy that's going to avoid complications and maximize outcomes. And we know that untreated hyponatremia is bad. It has unintended consequences and negative outcomes that can affect the patient's mental status. But we really worry about the rate of excessive correction of hyponatremia because of the risk of osmotic demyelination. So what's the data on correction? Well, this is really the best data source. And basically, in chronic cases, when you look at the patients who develop chronic sequelae, osmotic demyelination, it's in patients that typically have rapid rates of correction as defined by more than 12 milliequivalents occurring in 24 hours, or more than 18 milliequivalents in more than 48 hours. And this, again, is the best evidence base. You can look at the acute cases in this large case series and compendium. None of those patients develop neurological consequences. So what are the risk factors for osmotic demyelination? Who gets this and who do we worry about rapid rate of correction? Again, chronic hyponatremia, especially very low serum sodiums, less than 105. Patients who have concomitant hypokalemia, which can worsen the intracellular osmotic effects. Alcoholism and malnutrition. Patients with liver disease, especially post-liver transplant, where the rate of osmotic demyelination in patients with hyponatremia can be as high as 10%, and patients with hypoxemia. So again, the therapeutic goals in patients with more chronic hyponatremia is about 6 milliequivalents in 24 hours. Why 6 milliequivalents? Because that's going to be enough to take care of the severe symptoms, but really keep you away from that upper limit of 12 milliequivalents, which is so dangerous. How much is too much? More than 10 milliequivalents in the high-risk groups, more than 18 milliequivalents in 24 hours, and 48 hours, again, in those high risks. How much is right? Well, probably, again, about 6 milliequivalents is about really the sweet spot where you're not going to get in trouble. You're going to reverse the acute cerebral edema, but you're not going to come close to the risk of osmotic demyelination. The patients that you really worry about are the patients that have reversibly impaired water excretion, where you can have unintended overcorrection. These are patients where the urine osmolality all of a sudden falls to less than 100, and the patient begins to self-correct. These are patients that often have some component of reversible vasopressin secretion. They may be volume depleted, they may have acute nausea, they may have been on a drug that stopped, and the vasopressin levels fall very quickly because it has a very short half-life. The urine osmolality falls to less than 100, and the patient starts putting out a very dilute urine. These are the patients that you have to worry about because they're going to start correcting very quickly on their own. The urine output, you'll see, typically goes up to more than 500 cc's per hour, and the serum sodium will begin to self-correct by more than 2.5 milliequivalents per hour. And essentially, if you do the math, loss of about 3 mils per kilo of water raises your serum sodium about 1 milliequivalent. So basically, you want to treat these patients with the concomitant replacement of 3% sodium at 1 mil per kilo, and that will balance out that change of the loss of water. That's one way to do it. Remember again that a water diuresis is equivalent essentially to about 2.5 mils per kilo of 3% sodium chloride. So again, what about Vaptins for profound hyponatremia? There's limited published data with patients that have very low serum sodiums. The other thing that we worry about for these patients is that sometimes you can really slow the rate of correction by using DDAVP. But if you have a Vaptin that you've given to the patient, you can't do that because you're blocking the effects of the DDAVP at the vasopressin receptor. So this is the patients that can overcorrect from Vaptins. You do need to be careful. From these drugs that have been used in the treatment of chronic hyponatremia, though, there's still no reported cases in the literature of osmotic demyelination. Hypertonic saline, again, for profound hyponatremia, requires close monitoring, but the rate of overcorrection for hyponatremia tends to be very rare. Now, if you do get into trouble, can you relower the serum sodium? And the data seems to support the idea that if the patient overcorrects too fast, you can relower the serum sodium and sort of start over and go much slower. This is the seminal paper in neurology in 2001 that showed that that was feasible. The patient was corrected very rapidly, actually developed some neurological signs. The sodium was lowered back to a level that was deemed to be acceptable. Then it slowly rose after that. Now, I'm not going to talk too much about using DDAVP to prevent and reverse unintended overcorrection, but this is a paper where you can basically use DDAVP to clamp the urine osmolality and then subsequently lead to a more gradual rise in serum sodium. It's very difficult to do. It's something that requires a lot of attention and needs to be done in an ICU to do this correctly. Now, the last thing I want to just touch on is the use of urea for hyponatremia. This is something that I think is gaining a lot of traction worldwide. Certainly in Europe, it has been used extensively for many, many years. It was introduced in Belgium in the 1980s, and basically it acts like an osmotic agent to increase water excretion. And it's certainly recommended by the European Hyponatremia Guidelines in 2014. It's also a standard of care in Europe for the treatment of cerebral edema. Now, urea has been used extensively for acute SIADH. It's very effective. Basically, you use 30 grams of urea in a water solution or a beverage. That's administered orally through a nasogastric tube and can be given every 8 hours and leads to an osmotic diuresis and a rise in serum sodium that's actually quite nice and quite gradual and can be very effective at reversing hyponatremia. Caution, though, is that overcorrection from urea can occur. This is a series of ICU patients where the serum sodium was less than 115, and about a third of these patients actually corrected too fast. About more than 12 milliequivalents per 24 hours, or 18 over 24 hours, was actually in about a third of those patients. So you need, again, to be very cautious, even when you're using urea, that the rate of overcorrection can occur in about a third of patients. So I'll leave you with this in the last seconds, is the rule of sixes. Basically for safety, 6 milliequivalents per liter per day. For severe symptoms, 6 milliequivalents again per liter, and then stop. That will reverse the acute severe symptoms and is quite safe. So thank you very much for your attention.